Hey everybody, I'm Maggie and we're back on SRH Access Facebook Live.
Whoops.
We're live, gotta go with it.
It's all good.
Here, put it on vibrate.
All right, well we're here with our Chief of Staff, Dr. Dan Sucato, and we're excited because we're going to be talking about hip dysplasia. So how's it going? We haven't seen you in a while.
I know, it's been a long time. We're just talking about this.
Yeah.
I think we started our Facebook Live almost 2 years ago.
Yeah.
So it's been fun.
It has been. It's been
Yeah.
doing really great. And
I think we started right here.
we have.
First one.
Yeah, going back. All right, well, what's hip dysplasia, Dr. Sucato?
So hip dysplasia refers to where the socket of the hip is not formed as well as it should be. And so it's on the spectrum of developmental dysplasia of the hip, which hip dysplasia is the most mild form, where the socket just isn't as formed as it should be. So ball and socket, that's sort of normal. And then when the socket is not normal, it's sort of more steep. And so I oftentimes use my hands to sort of describe it. So normally it's supposed to be like this, where the socket now in hip dysplasia is sort of like this. So you're putting most of your weight on a small
So you
surface.
brought up DDH, which I think we talk a lot about, and
Yep.
we talked a lot about in March, that, you know, a lot with babies with DDH. So is there kind of any association with the two? In
Yeah.
terms as they grow older?
Yeah, it's a little confusing. So
Mhm.
developmental dysplasia of the hip
Mhm.
is a wide spectrum from a newborn baby that may have a hip that's dislocated or dislocatable. So a dislocated hip is the worst scenario, where the hip is out and sometimes can be put in, or it's out and can't be put in, to hip dysplasia, to DDH, where the hip is in but could easily be displaced. And then the spectrum runs from that to hip dysplasia, which never was detected early, which it couldn't have been detected early, to now the child is presenting with some symptoms or x-rays which look like hip dysplasia, and those symptoms can be a lot of different varieties. So it's a wide spectrum, DDH with a dislocated hip to hip dysplasia where the socket just isn't formed that well. And those patients can present at 10 years of age, 12 years of age, 40 years of age for the first time,
Oh,
you know,
wow.
with mild dysplasia.
Wow. So, I mean, there really is no, I mean, even with research, we're not really knowing where it's kind of coming from.
Yeah, I mean, I think that there are certainly risk factors for
Yeah.
DDH, you know, firstborn, female, family history. If you have a
Mhm.
family history of developmental dysplasia of the hip, that's that's important to know. And then breech presentation. If you're born feet first, then that is more likely that baby's more likely to have developmental dysplasia of the hip, because the leg is sort of positioned in a way that wants
Okay.
to drive that hip out of the socket.
So what are some of the symptoms? Because we know that parents, you know, especially if it's your first child,
Yes.
what should they be looking for in terms of the, you know, day-to-day, maybe if they're at activities, because I mean, if they're kind of a young adolescent, then
Yeah.
they're going to be in sports and stuff.
Yeah, so the symptoms can be typically pain in and around the hip. And so the first presenting symptom is usually pain on the side of the hip, because the muscles have to work a little bit extra when you have hip dysplasia. And so at the end of the day, they can have pain, and it's sort of a achy pain, one side more than the other. More commonly, the left hip is more affected than the right hip. And then as time goes on, they can get pain in the front of the hip. And that means that the hip joint is actually causing the pain, whereas the other one is just the hip's working a lot harder, so the muscles work harder, so that's muscle fatigue pain, whereas in the front of the hip it's more the joint pain, because the ball part of the hip is weight bearing on a smaller surface area, and that surface area tends to want to wear out with time, although in a child it's not worn out, it's just sort of going through that process where there's extra stress, and that results in pain.
We always talk about how, you know, obviously kids are growing, and
Mhm.
so the importance of really coming to a pediatric orthopedic specialist and
Yep.
for any of our conditions is really important. So what is the importance of coming for hip problems? Because it could probably progress. if
Yeah.
not
So
seen.
generally speaking, the earlier we see children with hip problems, including developmental dysplasia of the hip or hip dysplasia, the easier it is to take care of the child. Oftentimes we just watch them with time. You know, the x-ray, the nice thing about children is they have a great healing potential. So even if they have a little bit of a steeper slope socket, if they're still growing, if the growth plate of the hip socket's still developing, then they may grow out of it, or as we would say, that the hip will sort of remodel and become more normal. It doesn't have to be perfect at the end of growth, but it's certainly, we want to see it moving in the right direction. If it's not moving in the right direction, then treatment can be initiated. And it's easier to do it when they're younger than when they're older.
Are there certain activities that maybe would progress the condition in any way? Certain sports or something?
Not really.
Okay.
I think, in fact, we sort of, for children who have hip dysplasia and they're young and they're still growing, we certainly want kids to be active because I think the hip will have a better chance of developing normally. Now, there are positions or activities that may help, although it's not scientifically studied. For example, in children who have a little bit of steepness of the socket and they're very young, or children that we treat with the hip and put the hip in, we put them in a cast for a while, and then oftentimes we'll put them in a brace. And what the brace does is it takes the ball part of the hip and directs it towards the center of the socket, and at the center of the socket is the growth plate, and that the ball part of the hip deep in the socket with the hips out to the side helps that socket develop. So any position where the hips are out to the side, you know, riding a bike, horseback riding, those sort of activities probably help.
Right. So then you kind of briefly mentioned treatment. So I mean, obviously it depends on the child and kind of their case. So what are kind of the options in terms of surgical, non-surgical?
Yeah. So early on, so let's take the most severe case in the newborn. If we see them early, we can treat them with a Pavlik harness, which is a very soft sort of brace that helps direct the ball part of the hip towards the socket, and it's very effective. So the earlier we get to the babies, the better. Sometimes if that doesn't work or they're a little older and the hip is out of the socket, then we, under anesthesia, can put the ball part of the hip back into the socket and treat them with a cast. If that doesn't work at the same sitting, if we get the hip in but it's not super stable, then we sometimes have to do smaller surgery at that age. So that's one end of this spectrum. On the other end is if they have hip dysplasia and the socket is steep like this, instead of like this, then we can do a procedure where we actually take that socket and put it into a normal position, and very effective operation. In adolescence, where the child's growth plate is closed in the hip socket, we can do a surgery that not many places in the country do, and that's called a Bernese or Gans. Professor Gans was the gentleman that described this, and this is a procedure that we learned by visiting Gans. Myself and Dr. Pedeswa visited him and learned the procedure. We've been doing it here for the last 20 years. Very effective and can get the hip in a beautiful position. We do that on adolescents and even young adults here.
Cool, very cool. So long-term effects, you kind of mentioned that hip dysplasia can come at any point during lifespan. So if, let's say a child is diagnosed, or what are the potential that it could turn into adulthood? Yeah,
and that's really the question, you know, because children, when they're very young, they don't really have many symptoms. They may have a little bit of pain on the side, and then that may turn to the groin. That's usually in adolescence, and sometimes it's sort of silent. But what it can turn into is early osteoarthritis and the need for hip replacement. And so with these procedures or treatments, non-operative as well as operative, we want that child to have a normal socket, normal horizontal socket at the end of growth, or nearly normal, so that the biomechanics of the hip will be nearly normal or normal, and avoid early osteoarthritis, or certainly delay it for many, many years. So, and that's the goal. We want all children that leave this institution to have who have hip dysplasia as a diagnosis, to have a really normal socket, so that their hip can function normally, and children can go out, play, and do everything that they want to do with all activities, and not have hip problems in the future.
That's awesome. Okay, so I think to wrap things up, let's talk about research. I mean, that's a really big part of what we do here at the hospital. So,
it is.
And I know our hip research is very broad. So what's kind of going on with that? So
there's a lot of things going on with hip research, and everything from the newborns all the way up into the adolescents and young adults. So for every child, and we sort of had a prospective database where every child that came to the hospital who had a referral for developmental dysplasia of the hip, we didn't do anything different with those children, but we enrolled them in a study to allow us to gather data. And so we have a huge thousands of babies who we're following along to see what the natural history is. Oftentimes we looked at what's the referral pattern when pediatricians refer those patients in. you know, what is the likelihood of a patient with breech presentation, for example, that's one of those 4 risk factors, what's the likelihood of them needing or having hip dysplasia as they came in? And as it turns out, it was actually pretty low. And the pediatricians out in the community do an amazing job. I mean, they have to take care of so many things, and one of the things they do is screen these newborns, and their referrals are fantastic. And so we study that, we continue to study that. And so we have that prospective database of thousands of children. And then we also have, as they turn and get a little bit older, any patient that has treatment over 10, and we're probably going to lower that age, also is in a study. And now we're looking at really their function. So before and after these surgeries, are they functionally better? Not only in our eyes, but really most importantly in their eyes. You know, is my hip better? Am I able to do the things I want to do? You know, these children, they want to get back to doing the things that they enjoy doing, whether it's gymnastics, sports, dancing, etc. And so we ask them specific patient-related outcome scores, what they're doing, how they're doing. And then we also study them very scientifically with our movement science lab. And so we test their strength, we check their range of motion, we watch them walk with these high-speed cameras, you know, really high-tech technology, and it's really been useful. And we've changed. So, for example, we were doing this Bernese periosteotomy, and one of the benefits is it makes your abductor muscle, the muscle on the side, work better than the older surgery, one of the many benefits, so that you don't have that limp that you oftentimes see folks have. And as it turns out, we looked at that in the lab, and within 6 months, their strength was better, which was really a big difference. What was different, though, which we didn't anticipate, was their hip flexor power was weak. And so we changed not only the procedure, but we also, a little bit, in that we didn't take, we sort of left that hip flexor muscle alone. We didn't go near it at the time of surgery. And then we also focused our physical therapy post-operative regimen on not only the hip abductors, which we gained back strength in 6 months, but also our hip flexors. And now those patients have hip flexor power and abductor power. So it's been really, taking research to the clinical practice is really what it's all about. It's really useful. Yeah.
Very cool. Well, thank you so much for joining us this morning.
It's good to be back.
Busy Monday morning.
Yes.
So we appreciate it.
Thanks.
We'll
Great
see you
to be
next
here.
time.